Regal. Yeah, this is classic me.
Classic
yeah, pretty much. Oh man, so much going on. I wanted to start off. I mean, not the podcast, just telling you. I have been like, I feel like I've gone through a period of time where I've been just really like hating LinkedIn. And I don't know
I
if it's
can
like the
relate.
content or like the people are putting out, or it's the LinkedIn algorithms have changed so much, and LinkedIn just they pretty much suck. Like they're just it's a terrible platform. Now it's the only one I use because it's for business, right? And that's the one I started using 8 years ago, right? But I haven't felt like, oh, I want to put something out there. So I went like months without posting. Most people probably haven't noticed that. But, and I mean, we post like, I guess, about the podcast and stuff like that, but nothing like where I'm talking like an opinion, like on
thought
something.
pieces.
Right. And then I just recently, like this last week, I've been like, there's been so many people posting about AI stuff that I'm like, I don't believe you. Or I think that's bullshit what you're saying. Or it's kind of this like, I don't know how to describe it. Like, well, if you're not doing this, you're going to get left behind. And I'm like, are you? Like, is every single use case AI, like, so is every single use case like it's just a requirement now? You have to, like, no. And no one's scaling it at a scale. Like, here's the other thing. I haven't seen a single group scale it to a level that's like anything outside of a very simple thing. Scale it to an entire organization. It's not happening. And so, I don't know. I just got, I guess I wasn't doing anything, and now I'm like just adding comments to almost everyone's thing because I was like, I'm just pissed off. I can't, it's kind of like this reckless, like, look how great it is. And it's like, yeah, it's great. It's a great tool. But I've been like going down this. I'm getting ready for my forum, right? So which you're coming to, which is awesome.
Yep.
And I always do kind of an opening talk, and I've been trying to think like I was like, oh, what am I feeling? And then I always get like this rabbit hole. It's my own process, right? But my process this time was like, what does leadership look like in this era? And I think I might have been wrong on this one thing. So I had said that COVID was the largest shift in leadership management in the modern era, because I felt like because everyone went home and working remote required such a different. And I think I might be wrong, and like it actually isn't the largest shift. It might be that this is the largest shift because of this just, and I'm not saying AI is taking over everything, but it's like this identity crisis that people have, and then just this sheer like, we have to go implement all these things as quick as possible. What is being lost in all this, and where I'm starting to like get to, is I think that we have forgotten to give people agency. And what I mean by that is like, I've been studying more stuff from like Brene Brown and this other woman that does a fair amount of stuff on AI and has been doing for 15 years. It's really interesting. But it's like we're trying to create solutions that we're going to remove the person. But the problem is, or like, well, you should just use it. So it's like, you know why all of these things are failing, because they ultimately, like, we aren't like teaching the workforce or getting the workforce ready. Like, Susie's not ready to use the tool, or they're just like, well, no, I do this way. And I liken it back to like, I don't know, Dave, you remember this, but like, we implemented Epic once when I was at HealthRise. The health system implement Epic. This is back in 2012, maybe. It's not that long ago.
Yeah.
But we ran into people who did not know how to use a mouse, basically. And so it was, oh, we we're going to implement this new fancy system. But that person who didn't know how to use the mouse, I'll name her Susie because I name everyone Susie. It's my fictitious example, was a wizard with hotkeys. So it's like Control Shift F5,
Right.
and just moving around the screen like a wizard. Do you know how much we lost in efficiency by moving from that DOS-based system, which I get, there's lots of reasons why why people would move from it, to the new system? You know, at the time, I don't know what Epic's saying today, but at the time, Epic is saying you're going to cut out 30% of your staff. Houses were like banking on that. They're like, and we had to like add staff because it took people like, you know, especially in the beginning, it took people not just 10% longer, 20% longer. It was like 2 times as long to get through stuff because they were wizards in the old system. I guess my point is like, yeah, it might be fancy and it might do some stuff, but none of it is like replacing. None of it is a solution that doesn't need humans in the loop in some way. And so, anyway, it's just my rant of like my recent feelings, everything I'm saying and working on.
Well, I've been a believer for a long time that the future of RevCycle was touchless. And I would say in the last 12 months or so, a society seems to think that society is going to be touchless, meaning no humans. And then B, nuh-uh, is sort of my vibe, because it's
right.
I mean, I just read an article within the last week of some, you know, like a creative firm that had replaced all their writing staff with AI, you know, LLM type capabilities. And now they're bringing back a large proportion of their writing staff to vet and audit and correct what the AI is writing. And somebody interviewed, but they're bringing them back as almost like freelance rather than W-2 staff, right?
Sure,
because we don't pay
right.
benefits. And one of the writers interviewed for this article was saying something like, well, it takes me longer to fix what somebody else wrote than to have just written it from the ground up. So then now I'm making more money than I was making when I would just write for them, because now I'm essentially editing, right? And it's so it's the good old law of unintended consequences, right? Is like, yeah, you can automate your writing, you could automate your business process in RevCycle, you can automate this, you can automate that, but sort of then what, right? Which is a routine question I ask internally on lots of different endeavors at my organization. Is like, then what? Well, let's get a report on this. Okay, then what? Like, are we actually going to use that report to change something or fix something or whatever? Because if not, let's not spend the decision support time and your time and my time running a bunch of analytics to do nothing. Like, oh, that's neat. Cool. Moving on. Right. Like, what is the then what?
No, it's so true. It's the then what's awesome. I learned from this guy, Randy Essenberg, longtime right here. So Randy, if you're listening for some reason, that'd be awesome. He taught me this thing, which was like, don't measure anything you're not willing to do something about.
Mm-hmm.
And how many times we get in organizations where just what you described was like, we got 50 KPIs. I'm like, if you don't know when you're going to do something, and if you're actually willing to do something about it, what are you bothering? Why are you bothering?
The only asterisks I would put next to that are, unless you're measuring something that, you know, reporting on a dashboard or something like that, and really it should be behind the dashboard, that is the input or output to the thing that you care about. So that if the thing you care about is Catawompus, you can very quickly pull up the inputs and outputs and go, oh, that's Catawompus because the denominator's off because reasons, right? That'd be my only sort of asterisk to that.
Yeah, but okay,
you know,
there's nuance to it. I don't know what Catawompus means, but I'm guessing it's a name
askew, wrong,
else.
bad, you know.
Okay.
Sideways.
I actually wasn't sure what you were referring to. Is it just a name for anything? Was that what Catawompus is? No, it's a
Yeah,
name for
it's
something bad.
if
It's like sideways, like when sideways. Is
yeah,
that what Catawampus
sideways
is?
would be a good swap in
Okay.
for that. Yeah.
Yeah, we're definitely naming this podcast Cattywampus from
All right,
like the
cattywampus.
you know what
Well, the whole industry
healthcare
is
went
cattywampus
cattywampus
right
on
now.
us.
Yeah.
Amazing. Amazing.
I hear you about the LinkedIn as well. The AI hype is sort of mildly out of control. You posted, I don't know, a few months ago about how it seems like there's more and more ads as a proportion of the feed, which I
But yeah, I did
agree with.
I did some research and I was like, I know I'm actually curious, and I was
Right.
like going through my feed. It's crazy.
And there's that. And then what I struggle with, because I sort of just want to comment on all of it and then I don't, is what at least the algorithm chooses to put in front of me is such a wide array of sort of anti-hospital and anti-physician content or comments or whatever, and I really struggle with that because I'm like, okay, I'm not confident that the majority of hospitals and physicians are bad enough actors that they should be the ones that are getting everybody's ire. There are bad actors, like let's not deny that, right?
But
You
like,
know,
no,
so
I agree. I agree.
is that the majority? I don't think so, but maybe I'm just naive. I don't know.
I was watching I'm not saying this is like anyone should do this because this is actually pretty sad, but I was watching the C-SPAN uh Senate Committee on Aging,
Oh,
which
okay.
featured like Mark Cuban and three other people that are trying to do something in the health space. They were all the
Yeah.
rest were doctors, like had some kind of companies. But I love Cuban because I feel like he's just like cuts to the bullshit, right? And gets like right
Mhm.
to it. But there was like this senator, I think it was like Rick Scott, maybe. I don't know. He was like a governor of Florida. Does that sound right? A while back.
I think that sounds right.
Okay, so he does this like they do these. I don't watch much C-SPAN, but they do these like he starts the thing and then they have this pre-scripted thing that he reads, like so basically, and so does Cuban and like some of the others, and it's kind of whatever. It's like they're clearly reading from someone else that wrote this, right? But he had the gall. He basically had the gall to say, which I was like, wow, that was like okay, I guess you could say that. Well, he was basically like hospitals and their lack of like refusing to be transparent about their prices of what's causing all this, all these problems. And I was like, really? Like, like that's causing all the problems? I'm like, okay, well, get this. I was like, who is this Joker? And then, because at some point he says, like, well, I ran a company, a healthcare company, so I know this, right? And I was like, oh, wow, okay. Like, so he's got some background, but the way he was talking was like he doesn't really understand it, right? Because
Yeah.
like
Yeah.
you can tell if someone really understands it, right? So I look up, I look up who's Rick Scott and what company was he attached to, and this is from Wikipedia, so take it for what it's worth. But I feel like it's been vetted probably enough times. Well, it turns out he was the CEO and like one of the founders of Columbia Healthcare, which was HCA Columbia, right? And under his watch, and the reason he had to resign, got asked to resign, was because they defrauded Medicare and Medicaid to the tune of like they got fined back in the 80s for like $1.8 billion.
Oh my gosh.
And I was like,
I
$1.8
didn't know
billion
that.
today would be like 30 billion or 20
Right.
billion, right? I'm like, so you under your watch, you defrauded Medicare billing, and you want to have the goal to say it's like from hospitals, mind you. I was like, what is the irony of this is unbelievable.
Or maybe it's projection, right? Like if all of that is factual and true, and because everything you read on the internet's true, right? So we'll grain of salt it.
Yeah, agreed.
But if everything of that is true, maybe that's just projection. Like we did it, so everybody does it. Like no, that's
not everybody
actually
does
incorrect.
No, you did it. You got burned. You got caught. It's like an illegal gambling scheme. Like
Right.
at some point you're gonna get caught.
Right.
Not to say that's today's news or yesterday's news.
Right.
uh,
I think we could tackle that though, Ben. Okay, transparency. I struggle with the transparency laws over the last few years for a couple different reasons. One of them is I think they're actually anti-competitive, in the sense of in the past, and in meetings that I'm participate in for Ohio Hospital Association, the beginning of the meeting starts with a disclaimer from OHA's lawyer about antitrust, like don't share your rates, don't share your whatever, because that could lead to the perception, much less the reality, even the perception of price collusion between hospitals, right? Industries aren't supposed to, competitive industries aren't supposed to share pricing. The potato magnates are not supposed to set, jointly the prices of potatoes in the retail market, right? Like we're not supposed to do that. Yet I'm supposed to share my rates under the new law to the public in a machine readable format that anybody can pull down. Well, isn't that sort of going against the principles of anti-competitiveness? And now there are vendors popping up, scraping that stuff in order to sell it back to hospitals and say, oh, you want to see where you land in the marketplace of rates? I mean, so my first thing with this whole thing is it's anti-competitive. And I don't see how philosophically, if we don't agree with anti-competitive behavior by companies, then how is anti-competitive behavior supposed to help the patient? So that's my number one thing, is just the raw philosophical background of it. And then there's just the practical realities. Everybody's like, oh, it should be as easy as getting the price of your oil changed or whatever. I'm like, well, first of all, getting my car worked on is not always transparent. They'll go, oh, we think it's this many hours to do this work on your car, and we'll let you know when it's done, right? Like, so in that sense,
it's
that's
simple
actually,
when it's an oil change.
Yeah.
It's not simple when they don't know what's wrong, or
right,
they think
exactly.
what's wrong is something else.
Exactly. And
which is also my point back to what my talk was, which was the difference between maintenance,
yes,
and an actual event is very different.
Yes. You're exactly right. You're spot on. And in this metaphor, perhaps a basic X-ray is your oil change. And I can tell you the price of that. And I can even tell you what your insurance is probably going to pay. But for a gallbladder removal, that's going to be a lot tougher.
It's a lot harder. You're going to give an average, and then you'll be like, well, and then it could depend because you could have some other shit going on.
Right.
But let's go to your first point. I think your analogy is good because I don't know if it becomes anti-competitive. I would say that the difference is those markets are very different.
Mm-hmm.
The market that we live in, I'm going to say hospitals live in, is not competitive in the same way, because a good example is like, well, United Healthcare knows all the rates in all their markets. And so they're going to have, so this is, you could argue this is why health systems started merging into bigger and bigger health systems, because United did the same thing and they gobbled up all these local plans. And so they kind of took away all the competition, right? So they took away all the competition, which the U.S. government allowed them to do. And then the hospitals started doing a similar thing, but they just can't do it at the same scale. No matter how hard they try, they will not be able to do the same scale. And I don't think it actually helps them and any other function outside of negotiating contract, which is unfortunate. But I don't think those markets are this. They're not the same type of market. So the analogy of like, well, I know what was your analogy in the beginning? I go into what?
Well, my point was just like with Ohio Hospital Association, we get warned about antitrust and not sharing rates with each other.
Yeah,
but then you got to put them on the internet.
Who's been sued over this?
I don't know. Yeah,
exactly.
Somebody maybe. I literally don't know.
I would just like, if I were the hospital associations, I actually would just be, if I were them, here's what I would say. If I were them, I would just go full bore, like do everything that you can and see and push the line of what's possible. Now, someone's going to get sued. Fine. Countersue them. Do whatever you got to do. Figure it out in court, because I actually don't think what they're doing is illegal.
Well, I certainly think, given that again, there's companies aggregating this data and selling it back to hospitals. Why doesn't the hospital association just buy that data then and share that
Because
with their
it's
members?
right.
Like
It's not
then,
rates. It's what are you getting paid? What did you negotiate to get paid?
right,
It has nothing to do with the actual consumer, to be honest.
right, and yes,
And so that's probably the biggest difference. Is like this is an internal problem. This is like an internal problem of the sausage making behind the scenes, which unfortunately patients get screwed. But I mean, like that's a different issue. This is like the inside part of it. It's really fascinating.
yeah. And to your point about how much does it really matter to the consumer? It doesn't. What matters more to the consumer is like actual targeted estimates. And
Well,
I think,
fully understand their benefits. I mean, that's the hardest
and
part.
I was
What
just
they
thinking
did,
about how
what
to
they signed
phrase
up
it.
for, and they didn't know, and they like all of a sudden like, shit, I didn't know how to calculate that. I gotta what?
Right. Well, and a lot of the benefit, the plan benefit designs these days are massively convoluted. I mean, I live in this space, and understanding the benefits that my own family gets and uses, a 4-member household,
Right.
I have a hard time with it. And I do this for a living and generally think that I'm relatively savvy, and it's still,
I'm smart, damn it.
yeah, exactly. Right.
Like we're a tech company and we can't figure
Yeah.
out the PowerPoint. Yeah, that's how I feel sometimes. You're like, I really am smart. I don't know, still don't know, and I work in the business.
Right. And I still have trouble navigating it. And I think that's what's so frustrating, because I think that some of the in all of this, what gets lost is some of the commentary that I was expressing, hey, on LinkedIn. It's frustrating to read the anger at hospitals and physicians, is because of righteous frustration over the cost of healthcare and so forth. So, some of that is astroturf, some of that is misaligned or whatever, but some of it is, yeah, the cost of healthcare is really high, and I don't want to go into the in-depth in the weeds of all the different opinions of why and realities of why it's high. But the bottom line is, we providers have to try to do something different or better. I don't know what the answer is. We're trying to work through it at our organization. Because I don't know that we can solve the world's problems. And like, how much money do you want to spend on trying to merely educate the general public on their benefits, for example, that they're either they bought, or that their broker
they didn't buy
arranged,
it. That's
or
the
their
problem.
employer. Yeah. Like,
yeah, most of them aren't buying it. They're getting handed something.
yeah, exactly. And then the enterprise or organization handing it to them is clearly inadequately informing them about it. But then that doesn't fall on them. It falls on us. The anger falls on us, not their employer. So how do we solve for that?
I don't know. Did you see the latest on this? Like 4 of the main, 4 of the main for-profit insurance carriers in their quarterly earnings calls blamed health systems and their aggressive coding as a reason they didn't meet their targets.
I had not seen that. But
You've seen this. United was the most blatant, but like Molina, there's there's a few in that group. I could pull it up after this, but blamed it on aggressive. And so my friend Bob Booz, who's at Centra in North Carolina, South Carolina, Virginia. I'm sorry, Bob, I messed it up. I think Virginia. He was quoted in Becker's as like responding to this, right? And I was just like, oh my gosh, they like aggressive. Like okay, so we're getting better at following your clinical guidelines, which you change all the time. And we're now getting blamed. Like, this isn't upcoding. He made a good point. This is not upcoding. This is accurately trying to capture the acuity, and your patients are sicker than they were before. and we're trying to accurately capture the acuity, and we're getting better at doing that because we have to be, because this is like how this is basically how you kind of make up for all the denials you're sending us. So it's just fascinating to kind of be like, that's the reason that's why they're using this
That's what they're
reason.
blaming. I find that rich. I find that rich for two reasons in particular. One reason is several of those same companies are under federal, civil, or criminal investigation for upcoding their risk scores. So it's sort of rich for them to then say, "Oh, the providers are upcoding their risk scores." That's sort of funny. The second reason I find it rich,
it's humorous.
Yeah, humor. It's rich in a humorous way.
Oh yes, of course.
The second is that inside of, I think it's in OPPS as well as I know for sure it's in the IPPS, the annual rate changes that Medicare does have a coding improvement factor where they assume, and have done for ages, that providers are getting better at coding. And so to sort of hold things neutral or whatever for the feds, they adjust the IPPS changes from one year to the next in the proposed rule based on the likely or CMS perceived, or whoever figures this out, improvements in coding. So it's literally a governmental assumption that we are improving coding accuracy and efficiency over time, and they're offsetting against that. So if CMS knows exactly what you said, which is like, this is documentation accuracy, this is coding accuracy, and they're accounting for it in their dollars, then how is this suddenly acting as though it's a new phenomena to these companies when that's been part of IPPS rate setting for years, right? Like I just, again, I find it funny. Like, oh, this is news. That like CDI programs exist and people will optimize their charting. And once they optimize their charting, they might more accurately, capture codes. Oh my, it's like, that's just every company ever in any industry tries to do better every year. Like, come on, so,
and
no,
accurately capture again, it's your clinical guidelines. So you made the rules, which, okay, I guess that's okay. I guess you can change whatever clinical guidelines you want to use, but we're getting smarter about using technology to help us do that. But also, like, some of these other companies like Acuity and Smarter DX and others that are like prospectively looking to make sure like we captured all the acuity piece. Well, those guys, even when used together, are finding tons of money. And I say money as in like money because we're not capturing all the acuity levels because people are coming in sick. It's like, and it's not as simple as like, and this isn't, they're not capturing it like your point. They're not capturing on an x-ray. This is like big cases that are either surgeries that are very complicated or people who come in very sick to the ER and into the ortho emergency room, or an auto accident. These are ones that are like, these are complicated. These are not simple. People come with tons of comorbidities today. So it's just an interesting kind of like, that's the rhetoric we're going to use.
Are you looking for a judgment-free revenue cycle space? Do you want to expand your revenue management skills and learn insider strategies? Check out RevCycle 101. Unlock the foundations of healthcare finance with RevCycle 101, a comprehensive course designed to give anyone, from a recent graduate taking their first professional steps to a seasoned sales leader refining their expertise, the clarity and confidence to excel in revenue cycle management. Through easy-to-understand terminology, practical tools, and proven methods, this course demystifies the complexities of the revenue cycle. It equips you with the skills to drive results, optimize operational efficiency, and significantly advance your career in the shifting realities of today's healthcare industry. Click the link in the description for more information. Now back to the show.
Oh, well, I was going to say about part of the C-SPAN thing. So I'm not changing subjects.
Going back subjects is okay.
Well, Cuban had this great part because, Cuban's thing was on the price transparency. I guess the reason I brought it up was the transparency piece was he was saying that one of the areas that because his whole thing is the PBMs, right? So his whole thing's, for those who don't know, it's like pharmacy benefit managers. I don't understand completely this PBM space. Pharmacy is not my bag of tricks, but I get the idea of it. And basically these like wholesalers go through these PBMs and then they mark up and they get all these rebates, demand rebates and fees from the actual manufacturers to create these formulas, which all these insurance companies use. And by the way, most of the PBMs are owned by big insurance companies. So United, they all own them. What's fascinating is he's saying basically that there's no transparency and transparency of pricing to the actual consumer. So the consumer actually can't tell you the list price. He's like, his company is the only one showing every single drug that they have, what their actual cost is, and they only mark it up by 15%. So it's the only spot in the entire industry that you can actually see what the actual cost is. That's insane. So he likened at the very beginning, I thought this was a great analogy. He likened healthcare to Amazon. And I thought this was fascinating. He goes, in Amazon, they have 172 million subscribers, right? He's like, and all my Shark Tank companies, they hate getting on Amazon. They hate having to get on Amazon. Because what Amazon will do is they control all the networks. So they can control everything and they can demand a lower price. And then he's like, and they'll come up with knockoff products that will lower the price. And because they can do all that stuff. They can control it because they own 172 million of subscribers that will order through Amazon. He said, but healthcare and PBMs are basically the same thing. There's very few people controlling the whole amount of those formularies. It's always like tier pricing. It's all garbage. He's like, all this is garbage. Because it's all just a way like they can charge more money for each of them. And he's like, and their whole job is to lower costs. They don't do any of that because they get a percentage of the, like, let's say a drug $600, they get a percentage of it. I'm just like, oh my God. I mean, I knew this, but I didn't fully understand it. So it's just this fascinating, like, well, so I do think there's some cases where it's like, this is why it's like these blanket statements from these senators don't make no sense, right? So it's like, yeah, we just want everything needs to be transparent. It's free market. Well, it's not a fucking free market. It's just, let's be clear. Almost everyone's on some large employer that has an insurance product. It's not the same as I got to go to get my x-ray done and I'm paying out of pocket. That's almost never happening. But I do think there's a world in which absolutely there's stuff that the hospital does that they can give pricing to and be transparent about. I do think that exists. That list is probably, the basic stuff we talked about. There's this other piece of the pharmacy piece, which he's basically like separate the formulas from these PBMs and get rid of them. But he talked about, which you'll love this, getting into our other thing, which is what I talked about, was like, he was like, the key is actually getting direct contracting from employers. Because then it forces everyone to create, which is my whole point. If everyone's missed it, I did this talk at, I'm doing it again in Indiana, actually, HFMA in February. But I did it for Ohio HFMA, was kind of on the history of insurance, but getting into this space around what I think is the future. And the future is actually direct contract with employers. But he's basically talking about how like that can take out all this other BS, right? It takes it all out. And I was like, that's for transparency. But the health system's going to have to figure out how to like contract and know what their real cost is, which is what we discussed being an issue. It was a lot to throw at you, but
yeah, there's a number of complexities with direct contracting, but my crystal ball says it would be so much better. Some of the complexities are things like, hey, you have an employee who travels not even out of the state, but just 2 hours away to visit grandma and gets hurt. Like, if you're only direct contracting with your local hospital, how do you do that? Is it some sort of catastrophic? Is it a stop loss? Is it, what does that look like? So there's those practicalities. There's multi-state employers. How many places do you have to direct contract with, right? Do you have to, my little hospital plus a big hospital plus a hospital network, plus a physician group plus a pharmacy? And I just don't think that today the HR departments of the world are set up to do that. But I also think that how long can employers continue to sustain healthcare costs when you could cut a huge amount out? And I mean, I've joked recently with folks, maybe with you offline, but certainly with folks, I said, I take a 20% pay cut for a 10% reduction in complexity in my rev cycle world, because it's so complex. Like
Right.
even a small
I would take
change.
a personal pay cut.
Right, exactly. That's what I'm saying.
If my life was just a little bit easier.
Yeah, exactly. Because this stuff is so complex at this point, and direct contracting would help with that. Our hospital, even small, independent community hospital in Ohio, we've got a direct contract with a local employer where it's right up your maintenance versus big stuff alley. Their routine health and wellness and basic office visits, they pay us a PM, and everything else, then we
fantastic.
bill the insurance like normal. And you can come in. It's almost like employee concierge. We're almost like the concierge doctor for the company, and we've got an on-site clinic there. We even staff an NP in their company, so they can come and do the visits and do all that stuff right there. It's convenient to them. We honor that same thing then if they come to primary care elsewhere, not just, they don't have to go at the employee clinic or the employer clinic. And we've tried to replicate that with some other employers, and the big stuff still goes through benefits and everything like that. But by and large, that's been pretty successful for us. And on that front, the costs are straightforward. Like, what's our cost of labor of an NP and an MA embedded in that clinic? And then, a few visits outside of that office, the basic lab tests that are included and whatever. Like, even without a cost accounting system, we can get our costs on that because it's the basic stuff. It's back to on the price transfer. The complex stuff is where the complex costs come in. How many visits a day, how much, or how many hours of labor per day, per week, whatever, that's pretty straightforward. So we've had decent success, but I tend to agree with this idea that's kind of emerging, that direct employer contracting is a way to sort of save the American healthcare system. I think there's a number of other ideas that we can and should try. Because obviously, like, what if people aren't employed, whether it's because they're disabled,
yeah, but that's a
retired,
different,
but
I know exactly what you're saying.
I
I just think like one thing at a time.
Yeah, one thing at a time.
One thing at a time, man. But no, I love your thoughts on this. I also think I see this vision more and more of just little pieces, like almost like, you ever seen like we have this eagle. Okay, so we have a bald eagle that's like, we have this place in northern Michigan on a lake, and this bald eagle family like nest on this island out just directly out from my house, right?
Yeah,
It's
cool.
awesome. But the bald eagle just gets hammered by these little birds. It's all day. I mean, they're just like, if you see the bald eagle, there's little birds like coming up, just like trying to attack it, like all day. It's the wildest thing. And I don't know if like the bald eagle's trying to steal something from them, but it's constant, just nipping. And I see the healthcare system is a bit like that, where there's these little sucking things that just start nipping little pieces of the pie. PBMs is a good example, where they're taking a cut. And I hate to say it, but like, I know there's some value in insurance, right? But the problem is, like, they're still going to take their margin. So everyone's taking like a margin. Does this start making sense? Like,
Yep.
And then all of a sudden, yeah, costs are adding up so high because, like, well, yeah, I have to do this at a margin. And I get it, but it's like, but if some of those didn't exist, do I need a margin? I don't need a margin, right? Like, actually, like, because let me offer this. Okay, so you don't know exactly your costs, because it's very difficult in a health system. If you're listening to this and you don't really understand health system, especially when it gets very complex and complex care, it's hard to know exactly what it costs you. There's some, I think we can get there, but it's difficult. But if I offered you Medicaid rate Okay, Medicaid, straight Medicaid, not Medicaid HMOs. Medicaid rate on big issues, big cases, direct to an employer, but we're not going to do any denials. I'm really not going to need your rev cycle other than the fact that I'm going to require documentation, right? And we'll have a third party kind of look at it, make sure like things are set at the end of the year. We'll true up, but like there's going to be none of that. And you don't collect any copays. It's all paid. Would you take a Medicaid rate? You take a Medicaid rate all day, I think.
I'd certainly take a Medicare rate.
Things out.
I mean,
take those other things out. You don't need to do any of those things.
I'm trying to do the math off the top of my head because I know my broad strokes margin on Medicaid, but then like the other costs that I could remove, I would have to do a more sophisticated analysis on Medicaid, but I can tell you I'd take a Medicare rate because that I could be fine.
No, I think I think if you did the math, I haven't done the math fully. My guess is if you did the math, you'd take a Medicaid rate all day because you're not. Think of the fact of like you're only collecting 30 cents on a dollar maybe from a patient. So if you hit their deductible, you're screwed.
Mm-hmm.
I don't have to deal with any like administrative burden, like almost none. I could probably direct API with the provider or with the employer, right? So I could probably send over all the stuff. They see it. Here's what we did. My guess is everybody would do that. And for the employer, you're like, hell yeah, I'm signing up for that because
right.
It just cut my benefit costs 20%. Yeah. This is my point of like, could you cut 20 to 30% of the system for both sides? I think you can, and I think health systems would win.
Mm-hmm.
So I don't know.
Whether it's the
I'm making
Medicaid
up Medicaid
rate
rates. I don't know if that's like, but I'm trying to think of like something like easy where you could like, well, it's already established. I don't know.
Yeah, no, I get where you're coming from on that, and I just don't know. Medicaid rates are rough, but there's a number out there that hospitals can take that's less than commercial if you can actually reduce that administrative burden.
Because Medicaid's still coming back.
Save employers a huge amount of money.
They're still auditing and coming back, right? There's a third party for Medicaid that's coming back and taking money back from you.
Yeah.
Like those things still exist. Medicaid's not just as simple. It's not as simple as it was.
Right.
So
nothing's simple anymore. I also use that routinely internally. If somebody will bring me something, I'm like, well, nothing's simple. And I use that more of just sort of like de-stressor because somebody will bring me something like, we're trying to do an initiative or, hey, we ran into this obstacle and we figured out whether we can't do it this way. And how are we going to do it? And I'm like, well, nothing's simple. Let's sit down and figure it out, because it isn't. Nothing simple anymore.
Nothing simple. But Cuban's other point was, which I think is really powerful, most insurers aren't taking full risk anymore.
Mm-hmm.
So most insurers aren't taking the full risk. They're like pushing this off to PBMs and other things. They're like, this is why I'm saying like they're not taking the full risk. So he's like, employers, they're the ones paying the foot in the cost. As we've talked about before, 76% of large employers are self-insured. Yep. They're footing the bill anyways.
Right.
So if we talk about the history of insurance, which if you haven't seen, go see, but like part of that history of insurance is that the original insurance setup, you remember this, was that their argument was that health systems were the assets, the collateral,
right,
the reserve.
Yep.
They were the reserve that insurers didn't need reserves because hospital provided the care, which was the reserve. And today I would say, well, the employers are already fitting the bill, so they're the reserve. Both are assuming the most amount of risk in this whole thing, which is why it's also what pisses me off. And if I'm the employer, I'm actually taking on way more risk than the insurance. The insurance is almost no risk because they're not paying the bill. Like at the end of the day, it's like they're not paying the bill.
Right. Well, and two things on that, Ben. Like, so the first is ever since you presented on that and used that specific phrasing around the hospitals are the reserves, I think that the next big crisis in American healthcare is probably access and access problems due to closures. I think that you can't go a quarter without an article from Becker's about hospitals at risk or modern healthcare saying the same thing, or okay, so if the hospitals are the reserves and hospitals close, that means there's no reserves. And what does that mean? And I haven't figured out, like, okay, then what? Go back to then what, right? What happens if you have no reserve? But somebody better figure that answer out, because it's coming, I think, unfortunately. But the second thing where I couldn't agree more is, when it comes to talking about this stuff, sometimes you got to get down to sort of like first principles and really core basics and whatever. It's like, what is insurance? Well, insurance is risk pooling. If you're pooling to a risk aggregator that then sends the risk back to you, why do you need the risk aggregator, aka the insurance company? Like, if they're defraying that risk back to the employer, to your point, downward to the hospital or sideways to the hospital, or through high deductible, high out-of-pocket maximums to the individual patient, like, what are we doing? You know,
But it hasn't seemed to like do anything. I don't think the rate that I get as a small employer, like, we're actually getting to the point where we have, for Tarpon has to go out and get like rates, which I'm like hating, right? Because up to this point, I've only given people a stipend, go get your healthcare on HCA, right? Which is what I've done for 8 years, right? I've got my own insurance. I don't think it's much better. Like, I don't think an employer who's got 10,000 lives or 20,000 lives is much better than one with 50, because they're doing the same thing. So again, if I'm a large employer, let's just talk really large. Let me even step back further, because I heard a rumor today. Well, part of the Senate hearing committee, which I thought was interesting, was one of the senators said, well, right now there's employers that have physicians that work for them that are managing this.
Mm-hmm.
And they seem to be doing much better, but that's limited. That's very rare. And I didn't think about this fact, because what's interesting when I did my research was the first model of before insurance was what? Workers' comp.
Mm-hmm.
Remember back in the 20s, this was like actually how everything got started, was workers' comp. What's fascinating about this is, remember, the physicians were like all for it because they thought they were going to get all these patients. And what actually happened was the big employers hired a physician and built their own clinics and managed it themselves. And the physicians are like pissed that they got kept out of it, right? But I'm not saying that they should do this, but if I'm an employer, am I like, well, I'll just go buy a health... Would it actually be cheaper for them to go buy a health system and manage it themselves? I'm not saying to do this. I haven't thought of this through, but this is where my head starts going, is like, well, if I'm them, freaking who's the VC group or venture cap P group that bought the one in Suma?
But Suma? I can't remember the name.
I can't think of the name of it, but it doesn't matter. I'm like, if those fuckers can do it, like, I don't see why I can't do it.
Right.
I got more money than, if I'm, let's say I'm Corwell. If I'm Corwell,
Right.
I got more money than they do.
Right.
So, not Corwell. If I'm GM, I got way more money than they do. So why don't I go buy a hospital or plan and I'll just manage it for my own people? And then, yeah, we'll probably bring some other... Ford, do you want to join us? Sure. It almost eliminates the other piece of it, right? Well, then you don't need insurers.
Yeah, that's actually really interesting, Ben, because one of the things that I was thinking about the future of the rev cycle profession, if you have more direct employer contracting, is that it's possible that employers will want, claims and charging and coding experts on their team, and may want some version of a rev cycle person inside of the employer. And what you're saying is actually an extension of that. They may want whole provider capabilities inside of the employer, embedded. Then you don't really need the rev cycle folks, except for maybe like I said, the out of state or the management of that or whatever. But you just need the actual clinical medical operations inside of your employer. If you're a truly like super large,
I'm not
GM,
saying it works for
Deloitte,
everyone, but
Toyota,
if I'm the smart
Amazon.
ones, I was just thinking like, well, if I'm the smart one, I hire physicians and I have my own little clinic and everyone goes to the clinic. Like, when I was at Henry Ford. It was like Henry Ford had its own pharmacy, right? Like you just go to the pharmacy, and it was always, well, I'm like, if I'm GM or somebody, I'm not. Why am I not doing the same thing?
Right. Yeah.
I mean, maybe they have
you're
it. I just don't realize
self-insuring,
it. But it was like, it seems like, well, yeah, I probably could figure out like how I could actually like just take everything out of it.
Mm-hmm.
These, again, you're removing as many bloodsuckers from the system as you can. I get rid of the PBMs. I manage them. I don't need those guys. I don't need that. I'll direct contract with the manufacturers. I'll just go right with Cuban's group. Like,
Right.
I don't need any of that stuff.
Yeah.
How much money they would take out if they just did that?
Oh, I mean, a huge
can't
amount.
even
I've used
imagine.
his company. I don't use it for all my scripts, but I have
I compared
used
it to my scripts, and it's significant. I was like, holy I didn't even know I have good insurance. Well, that's don't get me started on that rabbit hole. Blue Cross Blue Shield of Michigan is my insurance, and I don't think they're on my high list right now of like big fans.
No, but
That's a different subject for another day.
Who is?
No, but you didn't see the op-ed piece that the CEO from Blue Cross Blue Shield of Michigan came out with.
No,
It's been all over the papers, and
well, I mean, we saw.
It's unbelievable. Blaming hospitals basically like for increasing prices. That was like the primary.
I feel like that's not new.
I know, but it's the fact they came out with it as an op-ed. The crazy thing is they have this. You know that person I follow on LinkedIn, Chris Deacon, who wrote that book, and she's great. Well, she's been doing this whole following of the Tierra Yachts case, which you're familiar with that, right? So this is the same. This is the same company, right?
Same leader, yeah.
Same Blue Cross Blue Shield, like, and in one sentence they're saying like this thing, and the exact like the way they're framing their argument is like that. Oh, we know we were overcharging you and screwing you on this, but you should have known. That was
you should have known. So too bad for you.
And I'm like, oh my god, she's so true. It's like it's so right. Like, you can't say one without the other. You're just, again, they're blood sucking off the employer.
Yeah,
that's their bread and butter.
Yeah,
not me, not some ACA plan. They don't give a shit about that.
Right. Well, I think that I go back to my understanding of, again, go back to the core principles, right, is fiduciary duty. And my understanding is an agent of somebody else or a company, the officer of a company can really only have a fiduciary duty to one party. Now, I'm not a lawyer, so nobody out there, in the comments or wherever you post this, like, oh, you're wrong. You can have more than one. Okay, cool. Correct the record. My understanding is you can only have one fiduciary duty. The officers of Anthem have a fiduciary duty to their shareholders, not to the beneficiaries, not to their customers. Because it's to the owner, which is the shareholders. So on one hand, like, I don't blame them for honoring their fiduciary duty to their shareholders, but the practical realities of people not understanding where their agents, and I'm using like lowercase a agent, right? Not their local agent, their broker. Not knowing where your agent's fiduciary duties lie is a major problem, because then you assume that they are interested in your financial well-being. Well, that case is clearly, to me, what I get from that is it's literally proving out, or at least their argument is basically proving out, our fiduciary duty wasn't to you, so too bad. Like, and which is sort of absurd when you think about it. But if it's true that you can only have one fiduciary duty, or a fiduciary duty to only one party, then their argument logically follows from that. Doesn't make it less wicked, doesn't make it less amazing to see them literally argue it in a court filing or whatever. But again, it's that core principles, right? If my broker has a fiduciary agent over here and my insurance TPA has a fiduciary duty over there and whatever, who has the fiduciary duty to me? Oh, that's right. Only me. Only me, HR leader in a company, only me, CEO of a company who, like, I think the employers out there are overdue for stepping up on this problem. I guess is, at the end of the day, that's what I'm saying.
No, they do. And Cuban was very clear who he blamed. He didn't blame the PBMs. He actually blamed the employers because they've
Okay.
been buying it. He goes, every year they buy it. He goes, so it's on them because they're at fault for this because they allowed it to happen. And I was like, oh, it's so true. It's like, oh yeah, we'll sign up for the same thing again. It's like an evergreen contract where you're just like, okay,
Right.
yeah, I guess tell us
Yep.
what our rates are. Like, you guys are managing that, right? It's like, no one's managing the store. And at some point, you got to be like, wait a second, what's happening? How is this affecting my? And that's the problem. That is ultimately the problem with all of this. Is at the end of the day, it's complicated enough, and you only care when you're really sick, and then you're like, oh, then I'm an advocate all of a sudden. And so, and I get it, like you don't have to access care, and then you do, and then you're really sick, or you're sick all the time, and then you're accessing it all the time. You're like, this system's messed up. I'm like, why am I paying this, or what am I paying for here? How did I get to that number? But until that point, this is also what I've always said about residual balances, right? It's like, people don't care. No one wants to hear this. I'm like, people do not care. And they get a balance and like, how did I get this balance? And it's 6 months later or whatever the time frame is, like, I'm not paying this. I don't even know what this is. And you wonder why people don't pay bills. I'm like, they don't pay bills because they don't care. They don't, like, ultimately, like, it doesn't matter at some point. Because they aren't sick very often and they never get it,
Right. Or there's the hope that it's wrong. Because there's the financial stats in the United States that about people's ability to absorb, surprise $500 bills. And I don't mean surprise bills like the No Surprises Act. I just mean a bill you didn't expect of $500. Like a huge proportion of American households can't absorb that. And so you get the bill for the CT or the bill for the ED visit that was 9 months ago and you forgot about because you're better now, and it's $1,000, and like, okay, it's how are they supposed to take care of that? And what's unfortunate, we've been on some work this year internally to really look at how do we do better with our like charity policies, with our payment plans, with our options, and educating people about their options and potentially educating them about their benefits, like we were talking about earlier. Like, how do we engage on that? How much money and resources do we have to potentially like add a person or hire a service or, do whatever to help with that more? Because what we find often is people just don't even know, what we, even though it's on the statement and it's on the website and, it's on the phone tree when you call, and it's like, if you need help, just raise your hand and like, we'll talk to you about it.
But it's
and
again,
people
this thing
don't
of,
engage with it.
I'm older, I'm coming in. I thought I had insurance to cover that. I don't. All of a sudden, I'm like, these other parties are asking me. Anestesia's sending me a bill. Like, what is all this?
I got a text from my mother yesterday. Like, do you know XYZ anesthesia? I'm like, I don't know, but I'm guessing that's from your surgery, Mom. Like, oh yeah, probably. She's making sure it wasn't a scam, which good for her because cyber's a real thing, particularly with the elderly. But, she's not wanting to give them info so I'm like, I don't know. It's probably from your surgery, Mom. But to your point, this stuff is Catawompus.
At the end of the day, that's what it is. Catawompus. I don't know. It's just an all-encompassing term, I think, at this point. Just like,
yeah, you can use it for
bad.
anything that's sort of askew. Just
it feels like very Dr. Seuss-ish.
I don't know the origins. I really don't. I picked it up. I think I picked it up from like Bernie Mac on one of his stand-up specials.
Oh yes, that's good.
Back in the day.
I thought you were gonna say Bernie Sanders, and that scared me somewhat.
No, Bernie Mac.
He's
rest in peace. Great comedian.
Great comedian.
And I'm pretty sure one of his specials, because it's a funny word, right?
It's a funny word, yes.
Just sort of using it by itself can be humorous, and then in line with whatever he was talking about was just dying laughing. This is like 20 years ago. So, and every now and then since I'll slip it in, and apparently it's a new word for you. So I'm glad that we could cover some vocabulary.
I mean, I
today.
feel like I've heard it, but then I don't think I realize the context, And sometimes you use words like out of context or like out of like not context. Like you think a word means this one thing and then it means something else.
Right.
Good example is for a long time I was using the phrase "jump the shark" in the wrong way.
Okay.
And I didn't fully understand what the context was, and then someone's like, "I don't think you're using that right." I'm like, "Am I? Am I?" And then they're like, and I was like, then Tina had to be like, "No, this is from the last Fonzie like Happy Days episode where they had
Like
him jump the
past
shark,
prime.
and they were like, "Oh, that's the end of this."
Yeah. Yeah.
Like they went too. They don't have anything else. They went too far. That was the end of the show. I was like the end of the show. That was it. So I was using it. I don't remember which way I was using it, but it was not the right way.
Not that way. Not the sort of the end of the good thing, the past its prime, those types of contexts, huh? Okay.
Yes.
All right.
I did not realize what it was from. So yes, we're using Catawompus, I think, the right way, which is like it's
I
messed up.
believe so. I am 77% confident.
That feels high, actually, like higher than I would have thought, if I was honest. You want to be like a 98% confidence intervals, but I think 77 feels pretty good for that term.
Yeah, I feel like a lot of decisions in life could be made quicker if people were a little more comfortable with like an 80% range. I think we hesitate for like perfect resolution in life a lot of times, and perfect resolution on data or on decision making is probably a myth.
That is true. Well, I don't think we solved healthcare, but I do feel like we definitely talked a lot of different types of topics that were all somewhat related. So I don't know. I feel like it was good.
Well, certainly Unscripted, which I know that's your new
anyway.
the new podcast way and methodology, and I think we've achieved that. So living up to the brand.
Yeah, no one could accuse me of like being real organized on this. But I've been called worse, I guess.
Fair enough. I think I probably have as well.
Yeah. Well, David, as always, a pleasure and fun to talk. We talked for an hour. I didn't even realize. I was like looking over, like, oh, it's like been an hour.
Time flies. Yeah, absolutely. Ben, I appreciate the opportunity. It's always good to see you and talk with you.
Yeah, good times. And I will see you in a few weeks.
Yep, absolutely, sir. Have a good one.
All right, thanks everybody. Appreciate it.
Bye, everybody.